Okay, hi everyone. My name's Ekene. I'll be doing the dermatology lecture today. Just a side note, I'm from a committee called DERMSOC, also called Monash Dermatology Society. We're a fairly new committee of students that are really passionate about delivering dermatology information to you guys. So definitely give us a follow and a like on our Facebook page. We've had a few events this year. We'll have more coming up next year, so definitely stay up to date with us. Okay, so before we get started, if you have any questions, please put them into the Google Doc. I've put a link in the revision lecture Facebook page. Just type out the questions there, and I can type in an answer for you guys, most likely tonight or like tomorrow night, just for the interest of time. So if you have any questions, just chuck them in there. So here are the dermatology matrix conditions. Today I'll mainly be going through the R1s, but there are a few R2s and 3s. Definitely come back to this slideshow and have a look at them as well. But yeah, mainly the R1s. Here's just a table with some dermatology terminology that can be really helpful when, someone's describing a rash or something like that. So definitely have a look at this because it can help, decode some of the language that's used. Okay, so we'll start off with the structure of the skin because that can be important when we're looking at different lesions. So there are three main parts of the skin. The top part is the epidermis, the middle part is the dermis, and the lowest part is the subcutaneous tissue slash hypodermis. And in particular, in the epidermis, the stratum basale is the lowest part of the epidermis, and this is where melanocytes are located. We'll talk about that a bit more when we're talking about melanomas. And then we have this basement membrane that separates the epidermis and then the dermis as well. Okay, so we'll start off with cellulitis. So this is a bacterial infection of the dermis and the subcutaneous tissue or the hypodermis. So typically, cellulitis will occur in the lower limbs of adults, or in children, it'll occur around the eyes, so the periorbital region. Some risk factors include any sort of injury to the skin that can be a means for bacteria to get in. Also sort of like fissuring of the toes or cracked heels as well. Anything like diabetes and venous disease can also be risk factors for cellulitis. So for the etiology, the most common causative organisms would be strep pyogenes. So this causes cellulitis 2/3 of the time. And then the other 1/3 of the time, it'll be Staph aureus. So that's really important to remember. So it's strep pyogenes and then Staph aureus as well. Other things can cause cellulitis, but it's not as common. So for clinical features, the patient will come and they'll have, a bright red swollen leg that's firm to touch. They, depending on, how sick they are, they may have systemic symptoms as well. So something like a fever too. For investigations, it's mainly a clinical diagnosis actually. So you do your history and your examination and you should be able to tell. But you can also do blood tests as well, and they may show raised white cell count and raised CRP because it's an infection. And you can also do a skin swab and, try and find out the causative agent. The thing with cellulitis is that it presents quite similarly to like other skin conditions. So just keep that in mind. Some differential diagnosis could be necrotizing fasciitis, DVT, septic arthritis, etc. So for management, general management, tell the patient to rest and elevate their leg because you're trying to get that inflammation down. Can also give them analgesia and compression stockings as well. And what they usually do is that they mark the edge of the swelling, and this helps you know whether the swelling is like sort of going down or whether it's increasing in the surface area. So if the patient has no systemic symptoms, it's just the infection of the leg, you'll give them oral antibiotics, and it depends on the causative organism. So if it's strep pyogenes, you'll give them methylpenicillin or benpen, or if it's Staph aureus, you'll give them flucloxacillin. If they have systemic symptoms, you'll want to give them intravenous antibiotics. So that'll be either benpen or fluclox, depending on what the causative pathogen is. And with cellulitis, there's the ability for the bacteria to spread to other parts of the body. So you will want to be looking out for complications like sepsis, endocarditis, osteomyelitis. amongst other things. And yeah, here's just a picture of cellulitis. Okay, we won't go through this today, but definitely have a look afterwards. Okay, so next we'll talk about leg ulcers / pressure sores. So this is the complete loss of the top layer of the skin, which the epidermal layer, and involvement of the epidermis and the subcutaneous layer. So there are different kinds of ulcers. So there's arterial / ischemic ulcers. There are venous ulcers, which are the most common. You have pressure ulcers / pressure sores, and you have neuropathic ulcers as well, and vasculitis ulcers as well, but that's more rare. So risk factors for ulcers would be pretty much anything that can cause insult to the blood vessels. So smoking, hypertension, obesity. Having a sedentary lifestyle is also a risk factor for arterial ulcers. And if you get a question that mentions anything about someone standing up for really long periods of time, it might be alluding to venous ulcers because, gravity is sort of causing the pooling of the vein, of the blood in the lower limbs. And yeah, that can be a risk factor to get venous ulcers. It's good to be able to identify what type of ulcer that they're talking about, depending on like the way that they describe it. So arterial / ischemic ulcers, they're going to be described as dry, quite painful. And they always talk about something like a punched out appearance. So it looks like it's been punched out. Whereas a venous ulcer, it looks quite wet. It's more superficial than an arterial ulcer as well. A neuropathic ulcer, they'll occur on high pressure areas, so like the bottom of the foot, and they occur in people with diabetes and peripheral neuropathy as well. And pressure ulcers, they occur on the bony prominences, and they'll talk about people who, are bedbound, not very, very sedentary, and have low mobility too. We'll definitely come back to this, please, if you have time, but okay, we have a question. A 70-year-old man presents with a pale pink lesion on his left cheek. It has been present for years. When stretched, the lesion has a clear pearly edge. What's the most likely diagnosis? I can hear some BCC and SCC. I have BCC in the chat. So, yep, to those of you who said, yeah, to those of you who said BCC, you're right. This is a BCC. The clear pearly edge definitely leads you towards BCC, as well as the fact that it's an older man as well, but we'll talk about it more. So BCCs are malignant proliferation of the basal stem cells in the stratum basale of the epidermis. So they happen as a result of DNA damage from like sun rays. And out of BCC, SCC, and melanoma, BCCs are the most common malignant skin condition. So some risk factors include chronic sun exposure, repeated episodes of sunburn as well, someone who's older and male, like in the question we saw before, and people with fair skin type. So generally they'll describe BCCs as, a pearly nodule with telangiectasia, and they have rolled or raised edges. So that's similar to how they described it here, clear pearly edge. So yeah. They have a lower potential to metastasize compared to SCCs and melanoma, but they can cause quite a bit of destruction like locally where they are. So that's why they also call it a rodent ulcer too. So fun fact. So here's some pictures. You can see it has like sort of like pearly sheen to it. It has rolled edges as well. You can see the blood vessels, so that's the telangiectasia as well. And if you have a look, it's located on this person's face. So it occurs on areas where there's a lot of sun exposure, so the face and the neck. So for investigations, you'll do a shave or an excision biopsy, send it off to pathology. And for management, you really want to emphasize sun protection, regular skin checks as well. And for surgical management, this is the main management, surgical excision with tissue sparing as well. There are other things there too, but I'd say surgical excision is the most important. Okay. So a 58-year-old farmer who received a renal transplant 3 years ago now has a new lesion on the lower lip, which has not healed for 3 weeks. What is the most likely diagnosis? Okay. So the answer is this one's, yeah, it's a bit more vague, but the answer is an SCC in this case. And we'll talk about it more. So SCCs are malignant proliferation of superficial keratinocytes within the epidermis. They're the second most common skin malignancy, but they're the most common in immunocompromised patients. So if we go back to the question, I think the fact that this man had received a renal transplant, it was alluding to the fact that he's probably immunosuppressed because he's taking immunosuppressants for his new kidney. Yeah, I think that was one thing alluding to SCC. Other risk factors include chronic sun exposure, being older and a male, having fair skin type, smoking as well is a risk factor. And so the way that they describe SCCs, they'll describe it as, scaly, erythematous, and having plaque, and quite tender to touch as well. They can metastasize, but it's not as likely for them to metastasize. And they generally will have an area of hyperkeratosis, which can undergo necrosis. So we'll have a look at a picture now. Excuse me. Um, yeah, so this is a picture of an SCC. So we can talk about the progression to an SCC. So it starts off as solar keratosis. Some people will call this sunspots. And this is where there's a few dysplastic cells in the epidermis. And then this can then become Bowen's disease, which is SCC in situ. And that's when the full thickness of the epidermis has dysplastic cells, but it hasn't yet broken into the basement membrane. And then SCC is where the dysplastic cells have broken through the basement membrane. Just to know about keratoacanthoma as well. This is a well-differentiated SCC. And you guys may have seen questions where it's like, they have a lesion that's growing on their face and then it regresses after a few weeks. So that's the keratoacanthoma. And they describe it as a smooth outer dome with a central keratotic plug. For investigations, again, you do an excision biopsy. And you can also check the lymph nodes in case it has metastasized. And for management, again, you'd emphasize sun protection, regular skin checks too. And management for SCC in particular will be an excisional biopsy, like we mentioned before. And you can also do adjuvant radiotherapy too. Okay, we have another question. 30-year-old suntan female comes to her GP because she's concerned about a dark freckle which has suddenly appeared on her left thigh. What is the most likely diagnosis? Okay, let's move on. So the answer is melanoma in this case. So let's talk about melanoma. So it's malignant proliferation of melanocytes in the stratum basale. And it's actually the least common skin malignancy out of all of them. However, it accounts for the highest number of skin cancer deaths. And that's really important to remember. Melanomas they're more likely to come from normal skin as opposed to sun damaged skin. However, sun exposure is still a risk factor for melanoma, but it doesn't have to be chronic sun exposure. It can more so be like sun exposure here and there rather than like years of it. Which means that it can happen in younger people as well. So other risk factors would be fair skin types, family history as well is a big one for melanoma too. And people who have many like nevi or freckles too are at risk. So there are different types of melanomas. You guys may know these already. So superficial spreading, that's the most common type of melanoma. And it grows like across the skin and metastasizes later. So that means it has a better prognosis. Whereas nodular melanoma has like the worst prognosis because it metastasizes quite quickly. Lentigo maligna melanoma, another one with a good prognosis, because it, has radial growth. And in questions, they'll talk about the fact that there's a lesion on the face of an older person and it comes from sun-damaged skin. Then we have acral lentiginous melanoma, and this is the one that appears on the soles and the palms of people's hands and feet. Unfortunately, this one has a poor survival rate because it has a later diagnosis. And it's more likely to occur in people with dark skin and people of Asian descent as well. So here are just some pictures here. So superficial spreading, lentigo maligna, nodular, and acral lentiginous. Okay. You guys may have heard about the ABCDE and then /EFG of melanoma, and this is just a way to describe a melanoma. It's really handy if if you're asked to do it. So A is for asymmetry, B is for border irregularity, C color variation, so if it's like 2 or more colors as opposed to just 1 color. D for diameter if it's over 6 millimeters. Evolution if it's changing in its appearance. E for elevated, F for firm, and G for whether it's growing or not. Okay, so we also have something called Breslow thickness. I think this came up in like some past exam papers, but pretty much what it is, it's like a good way, it's a way to see the prognosis of the melanoma. So depending on the thickness, the prognosis changes. So as it becomes thicker, unfortunately, the prognosis declines. And it also gives an indication of the margin to leave when you're doing a wide local excision too. So for investigations, you can do a total body examination looking for other potential lesions, and you do dermoscopy of anything that looks suspicious. You'll do an excisional biopsy, and you'll also do a sentinel node biopsy because remember, melanomas can metastasize. And you can also do imaging, so something like a full body CT or PET scan, to also looking for Mets too. This is also just like a pathology report if it is a melanoma. So, okay. So for management, again, sun protection. For melanomas in particularly, no tanning beds is a good idea because tanning beds can cause melanoma. And also advising the patient and teaching them how to do regular skin checks too, or going to their doctor for regular skin checks. So as we said before, you do a wide local excision. And you can also do a sentinel node biopsy. If the sentinel node is positive, then you can do a lymph node clearance, so like taking away the lymph nodes too. Okay, we have another question. So Michael is a 45-year-old man with severe eczema. He takes medication for this problem that inhibits the number of circulating lymphocytes and regulates Th1 and Th2 responses. What is the most likely drug? So pretty much what drug do you use to treat eczema, mainly? Yep, so we've got some answers. So to those of you who said C, good job. C is hydrocortisone, and we'll talk about that more now. Okay, so eczema is an inflammatory skin condition that is driven by T helper cells in a type 1's hypersensitivity reaction. So eczema is part of the atopic triad. And if you haven't heard of the atopic triad, that's a triad of 3 conditions. So eczema, asthma, and allergic rhinitis. And if you get someone who has one of these conditions, it's really important to ask about whether they have the other 2 conditions or whether they have a family history of the other 2 conditions as well. So eczema is quite common in infants, and it becomes less common as people get older. And the distribution of eczema on the body actually changes as well as we get older. So in infants, it's more likely to happen in their face and the scalp, whereas in children and adults, it'll occur on the flexural surfaces, and that's quite buzzwordy for eczema. So things like the popliteal fossa and the cubital fossa as well. So eczema can have some triggers that it's good to be aware of. So you can educate patients to sort of stay away from these triggers. So things like soaps, chemicals, allergens, wool in particular, can also trigger eczema too. So the way they'll describe eczema is that it's poorly demarcated erythematous patches. So poorly demarcated meaning like you can't really see where it begins and ends too well. It's kind of all just together. And it's associated with a lot of itchiness. And because, they're scratching so much, they can get excoriations in their skin too. There's also lichenification that can happen. So lichenification is thickening of the skin, and that occurs because of the chronic scratching as well. So eczema is mainly a clinical diagnosis too. You can also talk about like allergy testing and testing their IgE levels, but that's more so like a complementary thing that you could do rather than, helping you diagnose eczema in this case. This is a path findings. We'll just skip over that real quickly. Okay, so lifestyle. You want to tell the patient about, avoiding triggers. For bathing, there's a tendency for patients to take really long hot showers because it provides relief. But you need to tell them to, keep the showers shorter and take more lukewarm showers, and have soap-free baths as well, because that can, aggravate eczema if there's too much soap. For clothing, Okay, for clothing, you'll tell them about avoiding certain materials. And for damage prevention, you could talk about things like making sure your nails are short so that when you're scratching, it's not inflicting too much like harm to your skin, putting bandages on any wounds or anything like that. Regular emollients is really important. So emollients are moisturizers. And you may have heard of wet dressings. So wet dressings are when you wet like the dress. Okay, so they put moisturizer and like the topical corticosteroids. They wet the dressings and they wrap the patients like in the wet dressings, and pretty much it helps the moisture to just sink into the skin much better. Okay, there's a lot on the slide for pharmacological therapy, but the main one to remember is topical corticosteroids. And so the corticosteroids depend on what part of the face that there's eczema. Sorry, part of the body. So if it's on the face, you'll use a weaker steroid like hydrocortisone. If it's on the body, you'll use a stronger steroid like methylprednisolone. What else? Also for, the itching, it's also a good idea to give them an antihistamine to help with that as well. The rest is very specialized therapy that, dermatologists would most likely be doing for someone with eczema. But I would just remember, topical corticosteroids is the main stay of treatment, and making sure that they're applying like a lot of ointments, creams, or lotions to keep moisturized. There's some complications with eczema, but the main one I want to point out is that the fact that there can be secondary infection because, from the chronic scratching, there can be breaks in the skin, and that can be a way for bacteria to get in as well. And you treat this with either topical antibiotics or oral antibiotics if it's becoming more systemic. The other types of dermatitis, the other one I would probably point out is allergic contact dermatitis. You may know it from your OC Health already, but this one is a type 4 sensitivity reaction. And it's because of exposure to an allergen in this case. So it's different from atopic dermatitis. Okay, almost done. Okay, we have one more question, guys. So for the past decade, a 29-year-old man has had waxing and waning lesions shown in the image. The scalp, lumbosacral region, and the glans penis are also affected. For the past 2 years, he has had chronic arthritis of the hips and knees. What's the question? What's the most likely physical findings to be present? It's okay if you guys don't know this yet. But yeah, just have a crack at it. Okay, let's move on. So the answer is E, pitting of the nails. If you don't know that, we'll go through why this is the answer. So, psoriasis is a chronic autoimmune disease characterized by inflammation, erythema, and thicker skin. There are different types of psoriasis, but the ones that you guys would have most likely seen is plaque psoriasis. Oh, oops. So that's the one here. So that's the most common type. So risk factors include being young, having a family history of psoriasis, having other autoimmune diseases. Some non-modifiable risk factors would include smoking, alcohol, obesity, even emotional stress and trauma can provoke psoriasis as well and exacerbate it too. So definitely pay attention to this because they often describe psoriasis as erythematous salmon pink plaques with overlying silver scale that are well demarcated. And that's in comparison to eczema, which is poorly demarcated. So you can clearly see where each lesion is. There's another type of psoriasis, probably not as important for you guys, but it's called guttate psoriasis. And that's psoriasis that happens after a streptococcal infection. Okay, so this links to the question we had before. So in psoriasis, you can get nail involvement. And so what happens is you can get pitting of the nails, onycholysis, which I'm pretty sure is where the top part of your nail is peeling off. You can also get something called dactylitis, which is where the fingers look like sausages, like very thick. So definitely remember that there's nail involvement in psoriasis because I like to ask that sometimes. And you can also get psoriatic arthritis in people with psoriasis, and that can happen in like 30% of people who have psoriasis. They're also at an increased risk of cardiovascular disease. Okay, we're almost there, guys. We'll just skip over that one quickly. Okay, so for management, education, SNAP W, avoid triggers. For psoriasis, they say that gentle sun exposure can help as well, and moisturizing definitely. And for mild to moderate psoriasis, again, it's the topical corticosteroids. Sometimes a vitamin D analog cream can help as well. The rest is more so like specialist therapy, but definitely remember the corticosteroids and the general management too. What time is it? Okay, well, this is a quick comparison between eczema and psoriasis because sometimes you can get them mixed up. So just have a look at this later. Definitely have a look at this after too, and I think we're done. Sorry guys, I could only do the R1s, but good luck to everyone. If you have any questions, please put them in the Google Doc and I'll type out answers to them for you. Okay.